Types of regional anesthesia. 1. Central neuraxial block. Spinal, epidural, caudal. 2. Peripheral neuraxial block. All nerve blocks. Spinal cord ends at what vertebral levels in kids and adult? Children's, L2 per liter 3. Adult, L1. Indication for spinal anesthesia, lumbar puncture. Any surgery below umbilicus. Absolute contraindications of spinal anesthesia. 1. Raised ICP. 2. Bleeding tendency, aspirin clopidogrel hemophilia. 3. Local site infection. 4. Patient refusal. 5. Severe hypovolemia. 6. Mitral or aortic stenosis. 7. Allergy to anesthetic drug. Relative contraindications of spinal anesthesia. Hypotension, hypovolemia, uncontrolled hypertension, heart blocks, spine deformity, previous spinal surgery, neuropathy, CNS disorder, septicemia, chronic backache. Site for spinal anesthesia. Adult, L3 to 4. Kids, L4 to 5. Landmark for site of spinal anesthesia. Tuffier line, imaginary line joining two iliac crests. Pass between L4 to 5 interspace. Position for spinal anesthesia administration. Sitting, prone, left lateral. Layers encountered on passing needle for spinal anesthesia. Skin, subcutaneous layer, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, arachnoid. Spinal needles used for spinal anesthesia. 1. Dura cutting type Quink, Babcock. 2. Dura splitting type Whitaker, Sprott. PDPH postdural puncture headache incidents are more with what needle? More with Dura cutting type. Gauge of spinal needles and their relation with PDPH. Gauge, needle circumference, 18, 21, 22, 25. More is gauge, finer is needle, less CSF leak, less PDPH. PDPH is most commonly seen in, and its pathophysiology. In females after C-section, CSF leak, so loss of cushioning effect, so headache. Onset, site, nature, aggravating factors for PDPH. 24 to 48 hour after. Frontal and occipital region, dull, boring headache, aggravating, standing coughing, relieving factor rest. PDPH rare associations and its never associations. Rare, nausea, vomit, sixth nerve palsy, photophobia. Never, fever, neck rigidity. Treatment for PDPH. Bed rest, IV fluid, caffeine plus PCM. Epidural blood patch. Inject 10 to 15 ml of patient blood into epidural space, it clots and help healing. Ways to check block monitoring in spinal anesthesia. 1. Sensory level, by pin-prick sensation. 2. Motor level, by Bromage scale. Level of block done in LSCS. Up to T4. Level of block done in prostate surgeries. Up to T10. Level of block done in upper abdominal. T4. Level of block done in hip surgeries. Up to T10. Level of block done in foot and ankle surgeries. L2. Drug factors which affect level of block in spinal anesthesia. 1. Veracity. 2. Dose. 3. Temperature. 4. Viscosity. Veracity of drug and its relation to level of block. Its density of drug is compared to density of CSF. Hyperbaric drug have lower level block. Patient's factor that determine level of block in spinal anesthesia. 1. CSF volume, inverse relation. 2. Age, direct relation. 3. Pregnancy. 4. Height inverse. 5. Gender, male has higher block. Pregnancy and its relation with level of spinal anesthesia block. Dose should be reduced. 1. Gravid uterus, increase subarachnoid and epidural pressure. 2. Progesterone makes nerves more sensitive. Effect of Trendelenburg and reverse Trendelenburg position on level of block. Hyperbaric drug on Trendelenburg have higher level block and vice versa for reverse Trendelenburg. Hypobaric has higher levels on reverse Trendelenburg. Side effects of spinal anesthesia are due to sympathetic blockade. Side effect in their management of spinal anesthesia in CVS. 1. Bradycardia, atropine, glycopyrrolate. 2. Hypotension, phenylephrine in pregnant, ephedrine in non-pregnant, mephenteramine. Side effect in their management of spinal anesthesia in respiratory system. In low-level block, no effect. In high levels, paralysis of intercostal muscles leading to heaviness of chest. Give O2 supplementation. Side effect in their management of spinal anesthesia in GIT. Reverse peristalsis, relaxed sphincter. Manage, fast 6 to 8 hours before and prepare bowel bladder. Side effect in their management of spinal anesthesia in genitourinary system. Penile engorged, urinary retention, due to paralysis of detrusor muscle, management by Foley's catheter. Dermatome distribution of following landmarks, used in sensory block assessment. Umbilicus, nipple, angle of sternum. Umbilicus, T10, B.W. umbilicus and xiphisternum T8. Xiphisternum T6, nipple T4, angle of sternum T2. Relation between autonomic block segment, sensory and motor segment. ANS is 2 segment above sensory. Motor is 2 segment below sensory. Sensory is found out by dermatome. Drugs used in spinal anesthesia. Procaine, chlorprocaine, lidocaine not preferred, bupivacaine, levobupivacine, ropivacaine. Shortest acting anesthetic of choice for daycare anesthesia. Chlorprocaine. Additives added to spinal anesthesia and side effects. 1. Opioids, itching. 2. Alpha-2 agonist clonidine, dexmedetomidine. 3. Neostigmine, nausea. Which opioids are used as additives for spinal anesthesia? Morphine, side effect, delayed respiratory recovery. Fentanyl, sufentanil. Can adrenaline be used as additives in spinal anesthesia? No, can cause cord ischemia. Continuous spinal anesthesia technique has risk of cauda equina syndrome. Saddle anesthesia is used in anal region surgery. Taylor's approach in anesthesia is used if vertebral column fused ankylosing spondylitis. Complications of spinal anesthesia. PDPH, and spinal artery syndrome, permanent paraplegia, 6th nerve palsy, cord ischemia, meningitis, adhesive arachnoiditis.